Hello and welcome back to the series on congestive heart failure. I hope you've been enjoying learning about the basics of pharmacotherapy of CHF, understanding and therefore enjoying. Earlier we've seen what is the strategy of management and the key drugs used in management of congestive heart failure, and we've also seen the useful actions and effects of digoxin in management of congestive heart failure. Digoxin, the first drug introduced in management of this clinical situation. Now let us go on to see the other actions and effects of digoxin. Also the drug interactions which digoxin is capable of, and thereby understand what are the precautions we should take while using digoxin. We've already seen that digoxin is a selective positive inotropic agent. That is, it increases the force of contraction without increasing the heart rate. In fact, we said that digoxin reduces the heart rate. How does it do so? By inhibiting the SA node through direct action as well as through vagal stimulation. And therefore, digoxin can produce bradycardias. Digoxin is also capable of inhibiting or slowing down the AV conduction. And this can result in heart blocks or worsen the existing heart blocks. Another important action of digoxin affecting cardiac rhythm is shortening the refractory period of atrial fibers. What is this refractory period? It is the period during which the tissue is not able to respond to further commands. And if the atrial refractory period is reduced, it means the atria can start responding faster, and so that results in atrial tachyarrhythmia, like atrial flutter, where the rate of contraction could be 250 to 350 per minute, and fibrillation, which is even higher. Fibrillation occurs because reduction in atrial refractory period produced by digoxin is not uniform. It is inhomogeneous, that is, some fibers it is shortened to a greater extent than for the other fibers. And therefore, instead of contracting and relaxing as a chamber, some fibers will contract now, the others will contract later, respond later, and this results in fibrillation. Third important effect adversely affecting the rhythm is generation of ectopic pacemaker activity. What is ectopic pacemaker? Ectopic means at a site other than the normal pacemaker, which is the SA node. So some other tissue other than SA node starts generating impulses in the form of action potentials. And this adverse effect is actually an extension of the mechanism of the beneficial effect of digoxin. We discussed that digoxin increases the force of contraction by increasing the availability of calcium inside the myocytes. Calcium is positively charged, and increased amounts of calcium inside the myocytes takes the resting membrane potential closer to the threshold. And because this gap between resting and threshold is reduced, it leads to development of ectopic pacemaker activity, which can result in ventricular extrasystoles or bigeminy. Thus, digoxin can have useful actions on the heart as well as it can cause any type of arrhythmias. Based on all these actions, what are the uses of digoxin? One use we already have discussed, that is, it is the key drug which improves the basic problem in the myocardium. That is, it increases the force of contraction, and therefore it is used in management of congestive heart failure. Second indication of digoxin is in management of atrial flutter or fibrillation. How could this be? Because digoxin actually causes atrial flutter or fibrillation. To understand this, we must understand that atrial flutter and fibrillation by themselves are not life-threatening because atria are essentially receiving chambers. How much blood comes back to the heart depends on the blood volume and the venous tone and not the relaxation of atria. Similarly, blood coming from atria to the ventricles depends on the relaxation diastole of ventricles and not contraction of the atria. And therefore, atrial flutter or fibrillation does not cause any great impact on life. But if ventricles were to keep pace with the atria, if ventricles were to beat as fast as atria, they would not get enough time to fill and eject, and that would compromise cardiac output, that would compromise tissue perfusion, and the patient would immediately become symptomatic. Therefore, major concern in managing patients of atrial flutter or fibrillation is not controlling atrial rate, but to ensure that ventricles keep beating at effective rate, effective to fill and eject. This is achieved by delinking ventricles from the atria by slowing down AV conduction. And this is the action of digoxin, slowing down AV conduction, which is made use of in management of atrial flutter or fibrillation patients in order to control the ventricular rate, not correct the flutter or fibrillation. In fact, flutter may get converted into fibrillation under the influence of digoxin. Apart from these adverse effects, which may occur at levels very close to the therapeutic, that means digoxin has got a very narrow margin of safety. Digoxin also has a lot of drug interactions. Let's see the kinetic interactions first. Many drugs like antacids or lipid-lowering agent cholestyramine can reduce the absorption of digoxin, and many drugs like enzyme inducers phenobarbital can increase the biotransformation. Both these actions would reduce the availability of digoxin and thereby reduce the effect of digoxin. On the contrary, some drugs like atropine or tricyclic antidepressants which have anticholinergic action can increase the absorption of digoxin. Some drugs like quinidine, the calcium channel blockers having predominant cardiac action, that is verapamil or diltiazem, and another antiarrhythmic agent amiodarone, all of them can release or displace digoxin from tissue binding, thus make more free digoxin available for action. And certain other drugs, again quinidine or spironolactone, the potassium sparing diuretic, can reduce the excretion of digoxin. And all these three actions would increase the availability of digoxin, leading to increase in effect or even toxicity of digoxin. There are also some interesting and important dynamic interactions to remember. One of the 3Ds is diuretics. So in a patient of CHF, diuretics would be there along with digoxin. And diuretics can cause hypokalemia, which can increase the digoxin toxicity. Adrenergic drugs, sympathomimetic drugs, also increase the excitability of the tissue, reduce the refractory period. And therefore, if two are given together, the risk of tachyarrhythmias and ectopics increases. Beta blockers and calcium channel blockers have interesting interaction with digoxin. Both these drugs can reduce the force of contraction. They have negative inotropic action. This opposes the therapeutic effect and therefore it can worsen CHF or push the patient into acute failure. On the other hand, the effect of slowing down AV conduction is also done by these two drugs. So this effect gets added up and there's an increased risk of development of heart blocks or worsening of existing heart blocks. Thus, digoxin has a narrow margin of safety, plus it has got a lot of drug interactions. And these drug interactions can push the patient into digoxin toxicity, which manifests with GIT symptoms, cardiac symptoms, and CNS symptoms. So what are the GIT symptoms? Nausea, vomiting, and abdominal pain. And in 70% of individuals, these occur before the cardiac toxicity, before the patient starts manifesting different types of arrhythmias, bradycardia, AV blocks, or as we saw, it can cause supraventricular tachyarrhythmias or ventricular tachyarrhythmias. But we must remember that in 70% of the patients, GI toxicity or GI adverse effects manifest before cardiac toxicity. CNS adverse effects are delirium, confusion, dizziness, nightmares or weird dreams, and fatigue. Coming back to the point, GI adverse effects may occur before cardiac toxicity. So in a patient on digoxin, if he reports nausea, vomiting, it should not just be treated with antiemetics, but this should be considered as a warning signal warning that cardiac toxicity may soon follow. And therefore, at the earliest onset of these symptoms, we must stop digoxin. Not only stop digoxin, we have to also measure the potassium levels, because even if the digoxin levels are in the right place, low potassium can cause digoxin toxicity. And therefore, we monitor potassium as well. And if it is low, we administer potassium. We must remember that low or high potassium, both are bad for the heart. So administration of potassium to these patients would be dependent on the levels of digoxin estimated. And while giving digoxin, ECG should be very carefully monitored to ensure that there are no adverse effects of excess potassium as well. Whatever arrhythmia is present should be treated accordingly. For example, bradycardia would be treated with atropine, supraventricular tachyarrhythmias would be treated with propranolol, and ventricular with lignocaine. If there is excessive toxicity of digoxin, too much digoxin has been consumed, do you think we could use hemodialysis? No, because digoxin is very little present in the circulation. Most of it has got settled in some tissues like cardiac tissue, skeletal muscles, and liver. What indicates this? The very high value of volume of distribution. So digoxin has got 420 liters value of volume of distribution, which indicates that it is sequestered somewhere in the tissues. It is not present in the plasma, and therefore hemodialysis will not be able to remove it. Then what do we have to manage this excessive toxicity? We have antibodies against digoxin, digibind, which can go and capture digoxin wherever it is hiding and inactivate it. So for excessive toxicity of digoxin, we have digibind. So considering all these useful and adverse effects of digoxin, the narrow margin of safety, let's see what's the current status of digoxin in management of congestive heart failure. Though it is the only drug amongst the drugs used for chronic management, which actually corrects the basic problem, that is reduced force of contraction. It increases force of contraction, but it cannot halt the progression of the disease. So also it has a narrow margin of safety and a lot of drug interactions, which can transgress the required levels and thereby either reduce the effect or cause toxicity. And therefore, mainstay of management, chronic management of congestive heart failure today are drugs like AC inhibitors or angiotensin receptor blockers and beta blockers. Why? Because they give us quick and better symptomatic relief without toxicity, and importantly, both these drug classes can slow down the progression of the disease. Therefore, the mainstays AC inhibitors and beta blockers with diuretics and with digoxin as required. We'll discuss it again later. Another important thing about digoxin is that its T-half is very wide. It is 40 hours, and therefore daily administration can make it accumulate and cross the safe limits. Therefore, and along with the reason that narrow margin of safety, lot of drug interactions, and cumulative nature, clinicians prefer to keep digoxin to the minimum. So lowest dose, and to keep it even minimum, prevent accumulation, it may be recommended as alternate day treatment, or you may also come across weekend holidays. Take digoxin Monday to Friday and holiday on the weekend. So this completes our discussion on digoxin, and in the next sessions, next parts, we'll be talking about the other drugs, other important drugs, that is AC inhibitors, ARBs, beta blockers, and what they do to a patient of congestive heart failure. In what way are they beneficial? The various terminologies which we've been talking about while discussing the pathophysiology of congestive heart failure, useful actions, adverse effects of digoxin like refractory period, action potential, preload, afterload, all these have been elaborately discussed in the video on Introduction to Cardiovascular Pharmacology. Do see that video to get these concepts cleared. So we'll come back with AC inhibitors in the next